Diastolic function of the left ventricle, the basic and the simple. We are going to talk about how the left ventricular fills up. It fills due to several factors, but the three main factors associated with it are its relaxation, its compliance, and the left atrial contraction. Relaxation is an active process that spends energy, and in normals it lasts only for the initial third of the diastolic period, but is responsible for close to 70% of the final diastolic left ventricular volume. It accounts for the drop in the left ventricular pressure even though the mitral valve is already open and the blood is rushing in. Compliance is nothing but a pressure-volume relationship of a container, left ventricle. For the purist, distensibility is a muscle property, compliance is a container property, and stiffness the whole property. As volume increases inside the left ventricle, the pressure increases. During the initial diastole, compliance is not important, since there is not enough blood in the cavity and the left ventricle is still relaxing. Notice that when there is not yet much blood inside the cavity, a fair amount of volume does not increase much the pressure. However, during the final two-thirds of the diastolic period, it has a significant role. Relaxation is over, and as blood keeps entering the left ventricle, the pressure rises. At the end of the diastolic period, the left atrial contracts and the final amount of blood flows in. If the compliance is normal, when blood enters left ventricle by the last two-thirds of diastole, the pressure does not increase beyond normal. If the compliance is abnormal, even a small amount of coming blood will increase abnormally the left ventricle pressure. We can see in this pressure curve of the left ventricle. If there were not the compliance factor, just left ventricular relaxation, the left ventricle pressure curve would have a gradual decay till close to zero. This is what would happen if blood did not enter the cavity and the pressure drop was dependent only of the left ventricular relaxation. See that left ventricular relaxation is essential at the initial third of diastole and normally has no role at the last two-thirds of diastole. However, as the mitral valve opens about at this region of the left ventricular pressure here, blood starts to enter the left ventricle cavity, and two curves pressure are affecting the final left ventricular pressure now. One, due to left ventricular relaxation, tends to decrease this pressure, and the other, due to left ventricular compliance, tends to increase this pressure. At the initial third of diastole, what leads the pressure change is basically relaxation. Compliance is not essential at this moment. At the two-thirds of diastole, the relaxation is not relevant anymore, and compliance takes over the change in pressure. So, the methods to analyze left ventricular relaxation will take into consideration the fact that relaxation acts only during the initial third of diastole. If the relaxation is normal during this period, the left ventricular relaxes and enlarges actively, causing a negative pressure that sucks blood from the left atrium, and about 70% of the end diastolic volume will enter the left ventricle in this initial third. It corresponds to the left ventricular rapid filling phase. The remaining 30% of the final diastolic volume will enter the left ventricular cavity during diastase and left atrial contraction at the last diastolic two-thirds. Now, if there is a problem with relaxation, but with normal compliance, this filling process inverts, and 30% of the final volume enters during the initial one-third. Since the left ventricle walls are not relaxing correctly, and it does not cause a negative pressure, that sucks blood besides keeping a tonus longer than just the initial third. In this case, the last 2/3 of diastole accounts for 70% of the left ventricular final diastolic volume. Notice that with normal or abnormal relaxation, the final diastolic left ventricular volume will be the same. What was different was how it came to enter the left ventricular cavity. And if the compliance is normal, the end diastolic left ventricular pressure will be normal. All diastolic dysfunction due to primary myocardial origin starts initially with only a relaxation problem. Low compliance comes later in the process of diastolic dysfunction, even in restrictive cardiomyopathy. Let's see how the M-mode can show easily if the relaxation of the left ventricle is normal. If the left ventricular fills typically 70% of its final diastolic volume during the initial third of diastole and only 30% during the last 2/3, it is evident that the left atrial empties much more during the initial third period. That can be seen in an M mode showing the aorta and the left atrium. The aorta is displaced forward during ejection. This movement and the systolic pulling of the mitral annulus with the mitral valve closed are key factors to increase the volume of the left atrium and hence fills this cavity with blood. Since the aorta was displaced forward during systole, now it must return to its initial position. This return is due to elastic forces, and the allowed space for its displacement is given by the decreasing size of the left atrium as it empties in the left ventricle. Then, as the left ventricle is filling and the left atrium is emptying, the aorta is returning to its original position. In normal condition, the posterior aortic wall moves back intensely right after aortic valve closure, with a significant decrease in left atrial volume following the rapid filling of the left ventricle, and then more slowly during the remaining of diastole, and shows a small backward displacement with the atrial contraction. This sign is showing that the left atrium is emptying, hence the left ventricle is filling, much more intense during the initial third of diastole than in the late 2/3. Another example, intense return of the aorta with a significant decrease of LA in the initial diastolic third compared with the final third. This is an important sign of normal left ventricular relaxation. It's a good sign as long as you keep the two aortic walls pretty much parallel. It is a straightforward, sensitive, and specific sign as long as there is no obstruction to the free flow across the mitral valve. If left ventricular relaxation is low and abnormal, only 30% of the final left ventricular diastolic volume will leave the left atrium to enter the left ventricle during the initial third period of diastole. Then, final 70% occurs during the last 2/3, and the M mode will show a mild and slow backward movement of the aorta right after aortic valve closure, and a small decrease in the left atrial size. The reduction in left atrial size and the final return of the aorta is seen mostly during the last 2/3, mainly during atrial contraction. This is the first and easy sign of abnormal relaxation of the left ventricle. Another example, see the aorta returning poorly and very slowly during the initial diastole and more deeply at late diastole. Very simple to demonstrate the sign and very easy to understand its reason. Another way to demonstrate this delay of left ventricular filling by M mode is observing the mitral valve. EF slope delay. This is very simple to notice and very specific, as long as there is no mitral valve pathology. There is a relation between the flow of blood that occurs through the valve during the initial third of diastole and this slope. The greater this velocity, more the percentage of flow is happening during initial third of diastole. When the slope is lower, usually less than 70 millimeters per second, there is a left ventricular relaxation problem. Here, another example of intense EF slope decrease velocity.